Welcome to LG PathLab's monthly pathology webinar series. Today we have Dr. Ipshita with us, who is a consultant pathologist at St. Joseph's Hospital in Hamilton, Ontario in Canada. She's going to talk about head and neck pathology with special emphasis on special stains and ancillary techniques used in this region. Welcome, Dr. Ipshita.
Thank you, Dr. Gupta. So I'm going to be talking today about head and neck pathology. More specifically, I'm going to be touching on ancillary testing specifics in head and neck. We're going to look through some case-based examples and discuss some challenges with recent advances. So beginning with normal anatomy and histology, the oral cavity is actually composed of numerous different parts. So we'll start with the mobile tongue. Then we come to the floor of the mouth at the bottom. The teeth and the gingiva of the lower part, as well as the lower lip. And then moving back along the teeth, we've got the retromolar trigone, that's just behind the molars. And moving up, we've got the teeth again with the upper set, the upper gingiva, and the hard palate, along with the upper lip. So all of these make up the anatomical oral cavity. In terms of the oropharynx, the oropharynx is actually made up of specifically the soft palate, the pharyngeal wall behind, the uvula, the tonsils, palatine tonsils specifically, as well as the anterior and the posterior tonsillar pillars, and then finally the base or the root of the tongue that's behind the circumvallate papilla. In terms of the full head and neck anatomy, to actually see how they all correlate with each other, you can see that there are three regions that actually make up the pharynx. There's the nasopharynx, which is bounded by being behind the nasal cavity, as well as being right above the soft palate. There is the oropharynx, which we discussed. And then there is the laryngopharynx, or the hypopharynx as it's now called, that comes right below the epiglottic vallecula and then extends down below till the cricoid cartilage. The larynx, you can see, is designated differently as in this diagram. And so just to simplify, again, there are these regions of the pharynx: the nasopharynx in green, the oropharynx in yellow, and the hypopharynx or the laryngopharynx in blue. In terms of the normal histology, we'll start with the oral cavity and more specifically the anterior tongue. So the tongue is actually composed of these very specific papillary-like extensions of the squamous mucosa, and these are what we refer to as the papillae, as you can see here, and we have a much higher power coming up. Just below the squamous mucosa, you've actually got a thin layer of loose connective tissue, and then it's majorly made up of large muscle bundles. So these are skeletal muscle bundles that are arranged in at least 3 layers. So the tongue is actually quite a muscular organ. And all of the dark purple structures that you're seeing at this power are the serous acini, and the light or pale basophilic structures that you're seeing at this power are the mucous acini. So this is actually the main composition of the tongue. Here's a higher power of the same, where you can appreciate the papillae much better, the skeletal muscle, as well as the serous and the mucinous acini. In terms of normal histology of oropharynx, and again, specifically, we're going to talk about the palatine tonsil. You can see even at low power that it's actually very distinctly different from the tongue. So the squamous mucosa, while it's the same in the entire oral area, here you don't get the papillae that you get in the tongue. It seems quite relatively bland, but everything below is actually quite distinctly different. So even at this power, we can identify that there are actually a lot of lymphoid aggregates along with germinal centers that are present very obviously. And we can also see that the squamous mucosa actually dips down along these lymphoid follicles and then comes back up. These dipped areas are what are referred to as tonsillar crypts, and you can see cross sections of them below in the mucosa here and here as well. So the concept of tonsillar crypts is actually very important. So here I have a crypt in a medium power. And again, you can actually see the squamous mucosa and its intimate association actually with the lymphoid cells. And if we go a little higher, you can actually see that the lymphocytes are actually intermingled with the squamous mucosa. So not only are they present in the epithelium, there's actually quite a bit of intermingling between the lymphocytes and the squamous mucosa. At the ultrastructural level, this actually causes small breaks in the basement membrane of the squamous mucosa as these lymphocytes perforate through in multiple areas. This, as we know, is important for the function of the tonsil, which is to be a mucosa-associated lymphoid tissue that's going to present antigens for anything coming through the mouth. But it actually becomes extremely relevant when we come to tumors in this area. And just to complete off the other areas of the pharynx, we've got the nasopharynx, which is differentiated from the oropharynx because it's lined by sinonasal type or respiratory type mucosa. Still has lymphoid aggregates, although not as well formed as you get in the oropharynx. And then again, you get a combination of your acini. So as we come to what we refer to as the Waldear's ring, so it's these ring of mucosa-associated lymphoid tissue that's present in the head and neck. So two of them, the pharyngeal tonsil, you can see the anatomical relation here, and the tuban tonsil, which is located next to the eustachian tube, are actually, the histology is that of the nasopharynx because they come in the nasopharyngeal region, whereas the palatine tonsil, which we just saw, as well as the lingual tonsil, which is at the base of tongue, have the morphology that we saw for the oropharynx of the palatine tonsil. So the Waldear's ring in total is responsible for, like I said, the incoming antigenic stimula into the region of the pharynx. So that's why they have a lot of lymphoid aggregates. Okay, so let's move on to some case-based examples. Case 1, we're going to talk about an anterior tongue lesion. So a 60-year-old male presented with a non-healing ulcer of the lateral tongue that was growing in size. The CT showed an infiltrative superficial mass in the tongue, and the clinician decided to do a hemiglossectomy. So just on the first section alone, we can tell we're in the tongue. You can see the papillae really well and some actinomyces colonies, which are very common in the region of the oral cavity. And in another section of where the lesion was present, you can see a sharp transition between normal squamous mucosa and what obviously looks like a malignant infiltrative tumor. On higher power, we can appreciate the keratin pearls as well as the eosinophilic cytoplasm and the intercellular bridges that are readily obvious. So we know we're dealing with squamous cell carcinoma. In the region of the oral cavity, the main risk factors that are associated with squamous cell carcinoma are those related to tobacco or betel use, heavy alcohol consumption, UV radiation, and in some cases, immunosuppression. Squamous cell carcinoma is by far the most common malignant diagnosis in the oral cavity. Typically, this occurs in men in the 6th to 7th decade. And the tongue, especially the lateral and the ventral aspect, accounts for almost half of the cases. The lip, when it is involved or has a squamous cell carcinoma, which is most of the times in the lower lip, is mostly due to UV exposure. And the survival in terms of disease-free or overall survival correlates with the TNM staging. So just to get a look at the TNM staging, because this is where we come to one of our recent advances, I have put two protocols, both from the College of American Pathologists. This is the previous version. You can see it's version 3.3, and this is the newer version for the lip and oral cavity, version 4. And readily, the first thing that stands out is that there seems to be a lot of emphasis on depth of invasion. So you can see the depth of invasion actually influences now T staging in almost every component of the T, where it was not present in the previous protocol. And this is reflected in the Royal College of Pathologists UK guidelines, as well as in the International Collaboration on Cancer Reporting. So what is depth of invasion? So as described by all of these institutions, depth of invasion is measured as a perpendicular distance from the closest normal basement membrane to the deepest extent of the tumor. So you draw this perpendicular plumb line, as it's called, and that distance is referred to as the depth of invasion. So this is all good and fair when it's a tumor like this, which seems almost at level with the adjacent mucosa. But what do you actually do for exophytic or ulcerated lesions? So this is again described by the ICCR as well as all the other different institutions. An exophytic tumor, still you take the normal adjacent basement membrane and the deepest extent of the tumor. And in an ulcerated tumor, you still maintain the same. So it's the same concept, regardless of whether it's an exophytic tumor or an ulcerated tumor. So some of you might be thinking about, well, how is this different from tumor thickness? Because we are used to measuring tumor thickness in different areas. Depth of invasion, as we just discussed, is the perpendicular distance from the basement membrane of adjacent normal to the deepest point of the tumor invasion. Whereas tumor thickness is actually perpendicular distance between the highest mucosal surface of the tumor to the deepest point of invasion. So this might seem like it wouldn't sound very different, but it makes actually a huge difference when you're measuring exophytic and ulcerated lesions. So here's a really nice example from this paper by Dervin et al. That shows that for exophytic lesions, if you were to measure the tumor thickness, it would actually, from the tumor mucosal surface to the deepest point of invasion, it would overestimate the depth of invasion. Whereas if you were to do it for an ulcerated lesion, the tumor thickness, in this case it seems relatively similar, but it may underestimate the lesion. And to standardize that, depth of invasion was used as a better criterion that had more literature suggesting that it had impact on survival, and that's why it was incorporated into the recent TNM. Well, what about P16? We've heard a lot about P16 in head and neck. So do we do P16 in the context of an oral cavity or lip primary? So this is directly from a paper that I highly suggest reading because it's excellent with its synopsis of all the data that's present, as well as providing really helpful algorithmic approach to how to see cases in daily practice. And so according to this paper, which is a guideline from the College of American Pathologists as well, in a non-oropharyngeal primary, routine high-risk HPV testing is not indicated. So we don't do P16 testing when it's an oral cavity primary like we just had. And you might ask, well, why is that? There are a lot of papers that show that expression of P16 is actually independent of whether there's an HPV infection that's driving the malignancy. So as a direct quote from this paper, they state that whereas P16 was expressed in tongue squamous cell carcinoma, HPV16 was undetectable. Therefore, P16 cannot be used as a surrogate marker for high-risk HPV. And despite the presence of HPV receptors in the tongue squamous cell carcinoma, HPV prefers the tonsillar environment. And we'll talk about this just in a little bit. And here's another paper that essentially says the same thing, where squamous cell carcinomas of the oral cavity often overexpress P16, but rarely are driven by actually HPV pathogenesis. So we actually don't do routine P16 or any other high-risk HPV testing in the oral cavity. Okay, so from that, moving on to actual oropharynx, we'll talk about this case of a thickened tonsil. So a 55-year-old male presented with a rapidly enlarging cystic neck lymph nodes. The CT scan showed multiple cystic neck lymph nodes with an asymmetric left tonsil. So the left tonsil was larger compared to the right. Clinical exam also showed a thickened, slightly firm left tonsil with no obvious mucosal lesion. An excisional biopsy of the tonsil was performed, as well as a core needle biopsy of the enlarged neck lymph node. So this is an extremely low power view of the excisional biopsy of the tonsil. And you can see we're in the tonsil because we've got the squamous mucosa. And again, we've got it dipping to go into the tonsillar crypt. We've got our lymphoid aggregate, so we can readily identify we're in the tonsil. And even at this power, you can start seeing little nests of cells that look a slight different color or shade of blue compared to our lymphocytes. Here's another higher power of those. And here you can identify perhaps the cohesiveness a little bit better. If you compare these directly to the lymphocytes that are adjacent to them, these do appear to be not only more cohesive, but also slightly, like I said, a different shade of blue. And on high power, it can be very difficult to actually pick out these cells from the intermingled lymphocytes, but you can see that there are readily identifiable mitotic figures. In this field alone, we at least have 8 mitotic figures, which would be extremely unusual. The neck lymph node that was biopsied also shows the same picture. So we've got our lymphoid tissue and in the background, and we've got these nests of vague cohesive nests, which look like a different shade of blue. And when you do immunohistochemistry, these nests light up very well with P40. You can see how the normal squamous mucosa stains. And so we're obviously dealing with a squamous cell carcinoma. What about P16? And in this specific case, since it's an oropharyngeal primary, we actually go directly to performing P16 immunohistochemistry. Even the case of if you had only received that lymph node with that history, there is a clinically apparent primary with the thickness and the CT showing that the left tonsil is asymmetric. So in this case, you would go down the algorithm of yes, and the primary seems to be oropharyngeal because it was tonsil. So again, you'd go to doing P16, even in the lymph node. So here is the P16 immunohistochemistry. And when you look at it first, you might be a little confused because the surface mucosa also seems to be expressing P16, whereas it's obvious that the nests of malignant cells are highly expressing P16. But you might come to question that what exactly is considered positive? And that question is again answered in this paper by looking at a review of numerous papers looking at different cutoffs for P16. And they came up with it has to be more than 70% nuclear and cytoplasmic staining in order to call it P16 positive. So we go back to our case and we say more than 70%, yes, definitely looks 80 or 90% of the malignant nests look like they're expressing P16. And in terms of nuclear and cytoplasmic, we can attest to that as well, that both are staining. So this is actually a P16 positive squamous cell carcinoma in the oropharynx. So how do we report the final diagnosis? The left tonsil for the excisional biopsy, we call it squamous cell carcinoma, P16 positive / HPV associated. For the left neck lymph node, we call it metastatic HPV associated squamous cell carcinoma. And I usually put in a comment mentioning the exact P16 expression to make sure that if this case is reviewed again, that the positivity was very strictly based on the criteria from the paper. So some of the challenges that come in this specific context we'll deal with right now. So what if I only receive a lymph node biopsy with no known primary? So this actually goes into this algorithmic part of the table. So if you've got a cervical lymph node and there's no clinically apparent primary, it is a squamous cell carcinoma of unknown primary. The next thing that has to be ascertained is whether the lymph node that's involved is a level 2 or level 3 lymph node. If it is in fact a level 2 or 3 lymph node, you perform P16 immunohistochemistry, and the positive cutoff is the same. So you still use that to determine if it's positive. If your P16 IHC is positive and your tumor has a non-keratinizing morphology, then you report it as metastatic squamous cell carcinoma, HPV positive. If you have a P16 positive squamous cell carcinoma, but it's not non-keratinizing, you actually go ahead to do specific HPV high-risk testing. So this can be by ISH, by PCR, DNA, and if the high-risk HPV specific testing is positive, then you report it as metastatic squamous cell carcinoma. If it's negative, then you report it just as HPV negative. Now, if the lymph node that has this squamous cell carcinoma of unknown primary is not level 2 or 3, routine high-risk HPV testing is not indicated. So this is extremely important. If, however, you cannot actually determine the location, they've either not labeled it, or it's not clear from the radiology which lymph node they sampled, or you simply don't have that information, you go ahead and do P16 immunohistochemistry. Again, if the P16 is positive, you continue down the high-risk HPV testing, just like we did in the other example. And if it's negative, you just report it as negative. This is directly from the CAP guidelines as well, like I said. So the next question might be, well, what if I have a large tumor that seems to be involving in part the oropharynx, but it's not clear if it's actually arising from the oropharynx? So in other words, it's not clear if the oropharynx is the primary because it's just such a large tumor that I can't tell where it started. So this would again come under this part of the algorithm, which is a multisite tumor involving the oropharynx. So in that case, again, you do P16 immunohistochemistry first. If it's positive, you follow it up with high-risk HPV testing for being more specific. And if it's negative, you outright report it as HPV negative. What about how do I report P16 negative oropharyngeal squamous cell carcinomas? So typically for P16 positive oropharyngeals, we actually don't give grading, and grading is not recommended because the tumor is going to behave a certain way regardless of the grade. But in P16 negative or HPV negative, we report it just like we do with regular squamous cell carcinomas. So in this case, you would say squamous cell carcinoma, P16 negative, and then you would give the grade. And again, I usually try to put in a comment about what is the level of staining, just to give the clinician some confidence that, you know, this is quite overtly negative. And I also put in a comment that it's unlikely to be associated with HPV, especially in the region of the oropharynx if the P16 is negative. So if you'll notice, in the region of the oropharynx, once you perform P16 immunohistochemistry, you don't actually follow it up with any high-risk HPV testing because P16 testing in the oropharynx is an excellent surrogate marker for high-risk HPV. So you don't need to follow it up with ancillary testing, whether it's overtly positive or if it's overtly negative. So in both of those cases, you don't need to follow it up. So here you can see if there's no staining or less than 70%, just call it outright HPV negative and you give a grade, whereas in the HPV positive, grading is not applicable. What if I have a poorly differentiated or an undifferentiated malignancy? So it's AE1, AE3 positive or a broad spectrum cytokeratin positive, but it's actually negative for squamous specific markers such as CK56, P40. The first part of the algorithm is biopsy or resection showing squamous cell carcinoma. So all of this ancillary testing is only applicable if it histologically or immunohistochemistry shows squamous cell carcinoma. So if you've got something that looks like a poorly differentiated malignancy, you can't actually prove it's squamous, it might be neuroendocrine, this algorithm does not apply. So that's, again, extremely important. You actually have to first prove it's squamous cell carcinoma before doing all of this ancillary testing. You might ask, well, 70% being positive, is there an equivocal category between, completely negative for P16 and the more than 70%? And if yes, how do we proceed in those cases? And there's actually, as part of the paper, they've provided a section that says that if you've got equivocal staining, so that's considered between 50 to 70% nuclear and cytoplasmic, you should actually consider doing high-risk HPV testing. So this is the only area in an oropharyngeal primary where you might consider following up with high-risk HPV testing if the P16 looks like it's in this equivocal category of being between 50 to 70%. If it's less than 50%, it's outright negative. You don't need to follow it up with high-risk HPV testing. But the only category in which you might follow it up with high-risk HPV testing is this equivocal category. And finally, how do we deal with cytology specimens? Because we often get that from lymph nodes that they suspect are metastatic. And this is actually quite tricky. So very specifically, high-risk HPV testing is recommended to be performed on head and neck FNA samples. Again, you still have to prove that that metastatic tumor is a squamous cell carcinoma. If it's an adeno, if it's a neuroendocrine, does not apply. But if it is squamous cell carcinoma in a neck lymph node, and the patient either has a known oropharyngeal squamous that was not previously tested, or there is a suspected oropharyngeal squamous cell carcinoma. So it's not been biopsied, but there looks like there's a primary in the oropharynx. Or even if it's metastatic squamous cell carcinoma of unknown primary. So CT, clinical exam, PET cannot find a primary. In all of those cases, high-risk HPV testing is recommended. If the high-risk HPV testing on the FNA is negative, usually I put in a comment saying that there should be retesting done on a final tissue specimen when it becomes available, because we know we have limited material on FNA in cell blocks. For performing P16 immunohistochemistry on cytology samples, the lab needs to actually validate it on cytology samples in each institution, because the literature, there are numerous different cutoffs that have been used for P16 positivity in cytology specimens. So while there are some papers using the same cutoff, the 70%, there are others that use the 10% cutoff as well. So there's no good consensus in literature for what's considered P16 positive on immunohistochemistry in cell blocks. So typically, the recommendation is that in a cytology specimen, instead of doing P16 immunohistochemistry, especially if the lab hasn't validated it, it's better to do a high-risk HPV test directly. So again, ISH or PCR or any other method to directly test for HPV. So why do we care so much? Why are we talking so much in detail about P16 or HPV status? There's a lot of literature now showing that HPV positive oropharyngeal squamous cell carcinomas are biologically different from HPV negative oropharyngeal. So just to share some of the differences, HPV positive typically occurs in younger males who are former or never smokers. They have risk factors for exposure to high-risk HPV, just like in the region of the cervix or anal or vagina. These are typically smaller primary tumors, but present with early nodal metastasis. So if you remember the clinical vignette that I'd given with the tonsil are thickened, that's actually a very typical presentation for HPV positive oropharyngeal squamous cell carcinomas. They typically present first with multiple cystic enlarged lymph nodes, and then in the hunt for the primary, sometimes the CT or the clinical examination picks up an oropharyngeal primary, but in a vast percentage of oropharyngeal primary is not detected. So the neck lymph nodes are actually the first presentation of some of these tumors. The most important reason why we care so much is that there are improved clinical outcomes regardless of the grade of the tumor and the subtype of the tumor. They generally have a better prognosis than HPV negative stage for stage. So in HPV negative, this is our typical squamous cell carcinoma that we just spoke about, that is dependent on the grade, the subtype, and the TNM staging, and generally has a worse prognosis when compared to the HPV positive oropharyngeal. This importance of HPV is actually demonstrated in most recent cancer synoptic protocols. So this is the most recent one from the College of American Pathologists, and you can see that even to fill out a TNM, you need the P16 or HPV status, because it's different depending on HPV positive or HPV unrelated or negative oropharyngeal primary. And this also now affects the nodal staging. So in HPV positive squamous cell carcinoma of the oropharynx. In terms of the nodes, the only thing we need to know about is how many lymph nodes are positive. Whereas in HPV negative, all the traditional things that we look for oral cavity squamous cell carcinoma are still applicable. So the dimension of the largest metastatic deposit as well as extranodal extension. So you can see it's quite different between HPV positive and HPV negative. So this is why there's so much stress on P16 testing and HPV testing and its specifics in head and neck. So we'll move on to the last part, which is a nasopharyngeal mass. So a 50-year-old Asian male presents with enlarged posterior triangle lymph nodes. CT shows multiple enlarged cervical lymph nodes also with nasopharyngeal mass, and the clinician performs a biopsy of the nasopharyngeal mass. So here we've got a biopsy. It's quite a good chunk, excisional biopsy. And again, we identified that, there seems to be a vague clustering or a vague cohesiveness to some of these small round blue cells that again look like they're a different shade of blue compared to the lymphocytes. On higher power, it can actually be very difficult to pick up sometimes these lesions, especially when it's a very small biopsy or a very limited tumor. But again, if you focus closely on the lymphocytes adjacent to them, these cells appear to be larger and give a sense of cohesiveness. And this is just to show on high power that these cells are actually much larger than their adjacent lymphocytes. The nuclei are much more vesicular, and they do actually have some cytoplasm compared to their adjacent lymphocytes, which almost have none. Again, you do P40 testing, and you're surprised to actually see how much there is compared to what was apparent on the actual H&E. And this is very characteristic of these tumors. And similarly, if you were to stain with CK5-6, that would show a similar expression. So again, you're dealing with squamous cell carcinoma, but specifically now we're in the region of the nasopharynx. So nasopharyngeal carcinoma, the WHO classification actually divides it into 3 types: non-keratinizing, keratinizing, and basaloid type. The non-keratinizing is further divided into undifferentiated, which is the vast majority of cases, which is the typical H&E picture that I just showed. And this non-keratinizing subtype has a very strong association with EBV. So typically, nasopharyngeal carcinomas commonly affect younger males of Asian or North African descent. And again, very typically, in more than 70% of cases, they present first with asymptomatic lymphadenopathy, and that lymphadenopathy, as opposed to being level 2 and 3, like in the region of the oropharynx, this is typically posterior cervical triangle or superior jugular lymph nodes. And the primary, again, is typically occult. It's very difficult to find the primary. In terms of a small note about EBV, and this is where it becomes important to know how is your lab testing for EBV, because there are numerous different EBV viral proteins that can be tested, and they all are not the same level of sensitivity or specificity of detecting EBV in nasopharyngeal carcinomas. So just to give a very quick idea, the proteins that you can see in EBV include EBV-induced nuclear antigen, or EBNA, EBV latent membrane proteins, or LMP, and these are LMP1, 2A, and 2B, EBV-encoded small RNAs, which is EBER, and then we have microRNAs, which are just our RNAs. There is quite a bit of literature showing that LMP1 expression, so EBV LMP1, expression in nasopharyngeal carcinomas is highly variable, and it's anywhere between 20 to 40% of biopsies that actually show equivocal positivity, even when it's an EBV-driven nasopharyngeal carcinomas. So this is not a good test to actually pick up EBV associated pathogenesis in a nasopharyngeal carcinoma. A better test is actually EBER. EBER is highly expressed in all forms of EBV latency in nasopharyngeal carcinoma, and therefore is considered the gold standard. So instead of doing LMP1 immunohistochemistry, it's better in these cases to outright do EBER, because it's a much more sensitive and specific test for EBV detection in nasopharyngeal carcinomas. So this was the EBER in that case. And again, when it's positive, it's very overtly, easily interpretable as positive. It's a blue color, and so you can readily identify that, almost all tumor cells seem to be expressing EBER. So it's EBV associated, and this is nasopharyngeal carcinoma. And you might ask, what do I do if, the nasopharyngeal carcinoma looks like a typical non-keratinizing, undifferentiated type that I would expect to be positive, and I do EBER, which is the gold standard test, and it's negative? Is there anything else I need to do? And actually, there's recent literature showing that HPV is associated in small subset of these typical non-keratinizing phenotypes that are EBV negative. There's also literature showing that HPV might be associated with the other two subtypes of nasopharyngeal as well, so keratinizing and basaloid squamous cell carcinoma. So typically, if you get an EBV negative nasopharyngeal carcinoma, the recommendation is to then test for HPV, because you might identify this small subset. Okay, and with that, I'll stop, and hopefully that has clarified some of the questions that come around, not only the recent ancillary testing that we're now required to do for head and neck, but also some of the recent changes with the TNM staging in different areas, more specifically dealing with depth of invasion. Okay, thank you.
Many thanks, Dr. Ipshita, for such a lovely and informative presentation. If our viewers have any questions, please leave the questions in the comment box, and Dr. Ipshita Kak will get back to you as soon as possible. Thank you so much. Thanks, Dr. Ipshita.